Now we are going to continue with the clinical presentation of the complications. Now, for the clinical presentation of the complication, the first complication was hypoxic ischemic encephalopathy. When you want to evaluate hypoxic ischemic encephalopathy, you use the SANAT score. Is it clear? You use the SANAT score or you use the Thomson score. Is it clear? The SANAT score and the Thomson score are the two major scores that are going to help you to evaluate for hypoxic ischemic encephalopathy. In that SANAT score, you have to evaluate for the central nervous system examination. And the central nervous system examination, that there are four major elements. The first element, the five major elements. The first element is the level of consciousness. Second element is the reflexes. The third element is going to be the acoustic. The fourth element is going to be the acoustic. The fourth element is going to be the vision, and then the fifth element is going to be the tone. So those are the five major elements that you have to speak about in your central nervous system examination. And when you are assessing for the level of consciousness, in a child less than 2 years, you always use your Blantyre score. Is it clear? So those are the different elements that you have to evaluate here. Now, after evaluating the hypoxic ischemic encephalopathy, the SANAT score, the Thomson score, you can divide it if it is a mild, moderate, or severe hypoxic ischemic encephalopathy. Now, the next one, in periventricular leukomalacia, ventricular hemorrhage, you can just visualize signs of raised intracranial pressure, which can be shown with convulsion. Is it clear? Particularly, that is what you can have from a child. Is it clear? Now, the other elements after central nervous system, you are also going to have the cardiovascular system complication and the apnea-bradypnea syndrome. In the case of apnea, apnea is going to be considered when you have a cessation of respiration for about 20 seconds. When you have a cessation of respiration for 20 seconds, it's going to be apnea. And bradypnea is when you have respiratory rate is less than 40 cycles per minute in unit. Is it clear? And bradycardia is when you have the heart rate when it's less than 100 beats per minute in unit. Is it clear? So those are the different elements that you have to evaluate. Pattern doctors at the you can do on physical examination. You're going to hear murmurs at the level of the left subclavicular. Is it clear? Left subclavicular region. Now, for the atrial septal defect, you can see here a murmur at the level of the aortic. You have murmurs at the level of the aortic and the pulmonary area, which is radiating. Is it clear? So those are the different elements. In necrotizing enterocolitis, generally you are going to have dark residues at the level of necrotizing enterocolitis. You are going to have dark residues at the level of the you're going to visualize dark residues at the level of the nasogastric tube, and then the child is not going to defecate. It's going to have distended abdomen. Is it clear? So all those are elements that can tell you that there is necrotizing enterocolitis. So all that can tell you that there is necrotizing enterocolitis. Is it clear? So, in necrotizing enterocolitis, you're going to have distended abdomen, you're going to have the child is not going to defecate, you're going to have vomiting, and you also have residue which are going to be darkish. So all that shows the necrotizing enterocolitis. Now, the next element is going to be stress ulcer. In stress ulcer, you have instead the residues which are going to contain, which are going to be stained with blood, fresh blood. That's going to show you stress ulcers. Now, the other elements, you have hyponatremia, hypocalcemia, which are going to be particularly shown with convulsions. When you have hyponatremia, hypocalcemia, particularly shown with convulsion. Acute kidney injury is going to be shown with swelling of the body and no urination in the child. If you have a child which is going to be swollen and has no urination, shows with acute kidney injury. Now, when you have acidosis, you have acidotic encephalopathy, which is not going to be easily seen. Particularly, what shows acidosis is going to be the Kussmaul breathing, which is going to be shown with respiratory distress in the child, increased respiratory rate with an increased ramp of respiration, increased volume of respiration, and the child may also be vomiting because of intestinal obstruction that he has. The next one is hyperoxia. Generally, the complication related to hyperoxia vasoconstriction complication in relation to hyperoxia are mostly long-term complication. As the retinopathy of the newborn is going to be assessed with the central nervous system examination of the visual system, and it's going to be long-term. And for retinopathy and the other one, which is bronchopulmonary dysplasia, is also going to be assessed long-term when the saturation is always low despite management of the child, effective management of the child. Now, for the pressure, an increase in pressure and a decrease in carbon dioxide release, those are acute complications. So pneumothorax can result when you give excessive oxygen to the child. So those are the different elements. Now, the complication related to breastfeeding, we have hypoglycemia. The child may be floppy. Hypoglycemia is not it does not have a specific sign. It just have central nervous system signs that show that the child has reduced activity, is floppy and all that. We have also severe hyponatremia, hypocalcemia here. We have stress ulcer. We have reduced weight. That's why you need to monitor the weight of the child every time. So those are the different complications that you are going to evaluate. Now, for the pathogenesis, we said that the pathogenesis of birth asphyxia was divided mostly into two. And we said that there was a pathogenesis of acute fetal distress and there was a pathogenesis on fetal abnormality. Generally, the pathogenesis of fetal abnormality can only be visualized from echographies in the past. So when you have obstetric ultrasounds, is it clear? Obstetric ultrasound in the past, it is what can help you to know the fetal abnormalities, where you can visualize any congenital heart abnormalities, any lung abnormality in the fetal, in the obstetric ultrasound. So you need to know that what. Now, for acute fetal distress, we have to evaluate. You have to know that what the etiologies of acute fetal distress are always the acute fetal distress is diagnosed intrapartum. Is diagnosed intrapartum, and when it's diagnosed intrapartum, I've already told you the different elements that you have to use. You can use the fetal heart rate, use the fetal heart variability, and use the fetal heart acceleration. So those are the three major elements that you have to use in order to diagnose acute fetal distress. Now, the next element that you have to evaluate after the level of consciousness, we have seen the pathophysiology and clinical presentation. We are now going to move to the next part of our tutorial, which is prematurity.